one and all. And so now we'll be shifting gears and I'll show you a few slides about fetal anomalies and how scans are important in first, second, third trimester. So diabetes is increasing steadily with rates increasing from 2 to 4% of all live births. This is mainly due to increase in type 2 diabetes, which is a consequence of increasing proportion of obesity as well as advancing maternal age. So diabetes increases risks for both the mother and the fetus. Ultrasound evaluation is widely used for screening for fetal abnormalities, whether chromosomal or malformation. So antenatal ultrasound plays a crucial role in monitoring of fetal growth and well-being, and it helps detect complications early and guiding management. So what are the clinical needs for scans? Prediction of maternal complications including preeclampsia, fetal complications like fetal demise or fetal distress, diagnosis of fetal malformations, and to allow timely termination of pregnancy. And we can also diagnose abnormal growth patterns like macrosomia, helps in guidance for making decision on timing and mode of delivery. And the final goal is to improve the maternal outcome and the perinatal outcome. So what is the main pathophysiology? Maternal hyperglycemia induces fetal hyperglycemia and subsequent hyperinsulinism in the fetus. This is responsible for most of the fetal complications associated with diabetes. Achieving good glycemic control will decrease the risk of fetal malformations. So what is the role of routine ultrasound scan? Prevalence of fetal malformations is approximately 3% in the general population, and the risk gets increased 2 to 4 folds in a diabetic mother. This increased rate is closely related to increase in the HbA1c levels. The first 7 weeks following conception constitute the time where high blood glucose levels have the worst effect on the fetus. So the 2008 National Institute for Health guidelines recommend the following scans. So the first scan done at 7 to 9 weeks, that is the early ultrasound scan for gestational age and the viability of the fetus. Then the next scan is the 11 to 13 week scan, which is a nuchal translucency NT scan with a dual marker test. The third is the 18 to 20 week scan, which is a detailed anomaly scan with specific evaluation of the fetal heart. The next scans will be the growth scans, one scan at 28 weeks, 32 weeks and 36 weeks for monitoring of fetal growth, liquor and any evolving anomalies. So the early pregnancy scan is done at around 7 to 9 weeks to confirm viability and gestation age of the fetus. The next will be the nuchal translucency scan, which is done between 11 weeks to 13 weeks and 6 days. Here the crown rump length is between 44 to 84 millimeters. We take the nuchal translucency, we also look for any early anomalies, and the NT scan is done as a part of the first trimester screening, that is NT with a dual marker test for assessing risk of Down syndrome and aneuploidies. So increased nuchal translucency of more than 3.5 millimeters is associated with increased risk of cardiac anomalies even in chromosomally normal fetuses. If the NT goes to more than 4.5 millimeters, that is associated with a 15-fold increase in risk of heart diseases. And if it is more than 5.5 millimeters, it increases the risk by a 115-fold. Now, if these findings are noted in an already known diabetic mother, so NT scan should always be followed by a full fetal echo workup. So coming to ultrasound evaluation in second trimester, that is at 18 to 20 weeks. So we do a detailed anatomical assessment of the fetus. We look for the fetal growth, liquor, placenta, cervix, and a full fetal echo is done. So what are the cardiac malformations which are common to a diabetic mother? So mainly there is fetal hyperinsulinemia, which causes ventricular myocardial hypertrophy of the septal wall and less commonly of the free wall. And this occurs in both pre-gestation, that is PGDM and GDM. Here there is no LVOT obstruction, but there is decreased systolic and diastolic function. And most of the neonates are clinically asymptomatic. So what is septal hypertrophy? This is a complication of maternal GDM. Here there is no relation in between the macrosomia and the septal hypertrophy. There is preferential septal hypertrophy rather than the free wall, and it's a transient condition. So I'll just show you the ultrasound image. So this is a 4-chamber view. It's a 36-weeker, and this is how we measure the interventricular septum. So what are the other cardiac malformations? So transposition, muscular VSDs and TAPVC. So I'll show you a few cases that I have come across. Now she is a 24-weeker type 2 diabetes, and what we can see is a grossly abnormal 4-chamber view of the heart, and here there's a big atrioventricular septal defect with discordant size of the ventricles. And this is the Doppler image which is showing a big hole. So this is a case of complete AVSD. Now next is a 28-weeker, and she is a known case of GDM. And this is a 4-chamber view of the heart. Again, with this small muscular VSDs are very commonly seen in fetuses of GDM mothers. And this is the color Doppler image which is showing the VSD. Moving on to CNS and spine malformation. So diabetic mothers have a relative risk of major CNS malformation of 7.4 with an absolute risk of 2.5% of live births. Most frequently associated malformations are anencephaly, hydrocephalus and spina bifida. Caudal regression syndrome. What is caudal regression? It's defined by absence of sacrum, that is sacrococcygeal agenesis, and defects of variable portions of lumbar spine. So I'll just show you few CNS cases. Now she is actually a case of type 1 diabetic. She came at 17 weeks, and this is the axial section of the fetal head. So we can see that there is scalloping of frontal bones over here. And when we looked at the spine, so this is the lower portion of the spine. So this is a cystic mass which is seen at the lumbosacral region. So this is a sacral meningocele. This is another image of the same, which is showing a lumbosacral meningocele. Okay. My next case will be she's a 21-weeker and IVF, and she had a type 2 diabetes. So what we see again, this is a axial section of the fetal head. Again, there is a huge cystic lesion which is seen in the cerebellar region, which is causing spraying of the cerebellar hemispheres. The sagittal image, so this was a case of Dandy Walker malformation. This fetus also had an abnormal facial profile as is seen in this image, and bilateral hydronephrosis. So what are the other malformations which are seen? So fetal embryopathy, that is renal agenesis, rib abnormalities, hemivertebra, multicystic kidneys, hydronephrosis, single umbilical artery, cleft palate and vertebral abnormalities. I'll just show you few cases quickly. So 15-weeker type 2 diabetic. So this is the facial profile. We all can see that the chin is receding. So this was a case of micrognathia. Another patient, 22-weeker, type 2 diabetic. Again, we can see this is a facial profile and there is a grossly receding chin. So this was a case of micrognathia with retrognathia. This is a 3D image of the fetus where we can see that there is hardly any chin visible. And there were also abnormal ears in this patient. So my next case is 22-weeker. Again, we can see type 2 diabetic and there is a receding chin. So this was a case of micrognathia. This is a 3D image where the micrognathia is clearly evident. So another patient, 22-weeker, again a type 2 diabetic, IVF conception. Here this is a facial profile we can make out as a grossly abnormal facial with mid-facial hypoplasia. And this is a 3D image of the fetus. This is called as a flat face and Benders faces, which is very commonly seen in diabetic mothers. Another patient, 24-weeker, type 2 diabetic again. So the 3D image, we can see that there is a cleft of the lip. This is a cleft lip over here. This is a 2D image which is showing a break in the lip. So this is again a cleft lip. So another patient, 16-weeker, she's a type 1 diabetic, and here we can see that there is no left kidney seen. This is the right kidney over here, echogenic with the pelvis, and left kidney was absent in this fetus. Another patient, type 2 diabetic again. She came at 24 weeks for an anomaly scan, and this is a single umbilical artery over here. Duplex system on the left kidney. And here we can see the 4-chamber view of the heart where there's a big inlet VSD. This is a Doppler image which is showing us the VSD. She also had an aberrant right subclavian artery and an abnormal face. So again a flat face in this fetus. So moving on to third trimester, evaluation of fetal growth. So growth pattern in pregnancy in pre-existing diabetes, mainly what we see is a large for gestational age fetus where the effective fetal weight is more than 90th centile for the period of gestation. And in such babies, we see an increase in the fetal liver volume. So moving on to gestational diabetes. Gestational diabetes is one of the most common metabolic medical complications seen, and GDM is defined as any degree of glucose intolerance with onset of first recognition during pregnancy. There is associated growth disturbance like accelerated growth pattern, which is seen from 24 weeks onwards, macrosomia with associated complications. So in infants, what it does is it increases the risk of shoulder dystocia, clavicle fracture, brachius plexus injury, and increases the need for admission to the NICU. To the mother, there is increased chances of a cesarean delivery, postpartum bleeding, and lacerations. So what is a growth pattern in GDM and a non-GDM pregnancy? So here the growth acceleration takes place in GDM at 24 weeks onwards, and prior to 24 weeks, the growth pattern is usually similar in both GDM and non-GDM pregnancies. So moving on to macrosomia. What is macrosomia? Macrosomia is a term which is used to define newborns who are significantly larger than average birth weight of more than 4,000 grams. The fetal weight is corresponding to more than 90th centile. Between 15 to 45% of newborns of mothers with GDM are macrosomic. And it is important to note that macrosomic infants of women with GDM have higher risk of becoming overweight and obese at a young age and to develop type 2 diabetes later in life. Maternal diabetes during pregnancy can also lead to risk of transgenerational transmission of diabetes. Also, fetuses of obese women with GDM have a higher risk of developing macrosomia than those of non-obese with GDM. So what is modified Pedersen's hypothesis? It states that impaired maternal glycemic control results in hyperglycemia. Glucose crosses the placenta. However, insulin cannot cross. So that leads to increased insulin secretion by the fetal pancreas, causing hyperinsulinemia. So the combination of hyperglycemia and hyperinsulinemia leads to increased protein and fat stores in the fetus. So this is resulting in macrosomia. So what is a growth pattern in macrosomic fetuses? Is a unique pattern of overgrowth which is involving the central deposition of subcutaneous fat in the abdominal and the interscapular areas. They have a larger shoulder and extremity circumference and decreased head to shoulder ratio. So the prenatal prediction is important due to associated maternal and neonatal morbidity. So what are the growth patterns in macrosomia? Effective fetal weight or the abdominal circumference more than the 90th centile for the period of gestation. The HC to AC ratio would be less than the 5th centile, large shoulders and adiposity around the scapula. There's increase in size of the liver and in the subcutaneous fat which causes increased abdominal circumference. Subcutaneous fat is increased over the trunk and in the limbs and the cheeks, giving rise to the baggy cheek appearance. And this occurs in late second and third trimesters. So how do we assess the growth? The abdominal circumference, however, is not a very sensitive fetal parameter for the detection of fetal overgrowth because the estimated fetal weight and the abdominal circumference show a wide range of error of plus or minus 10%, and so that could impact clinical practice. So due to the unique pattern of overgrowth in macrosomia, fat mass and lean mass measurements are taken. So fat and lean body mass areas in the fetus are measured on an axial sections of upper arm, mid-thigh, abdominal circumference and subscapular regions. So what are the subcutaneous fatty tissue measurements? They mainly serve as predictors of macrosomia. So what are the measurements that we take? One is the cheek-to-cheek diameter, anterior abdominal wall subcutaneous fat thickness, mid-thigh subcutaneous fat thickness, subscapular fat thickness, and mid-arm subcutaneous fat thickness. And we also take the fat mass to lean mass ratio. So the fetal anterior abdominal wall thickness is simple, easily taken measurement that can be obtained from the abdominal circumference view, and this thickness is significantly greater in GDM fetuses. So this is how we measure the anterior abdominal fat thickness. This is how we measure. So this is the image which is showing a scapula of a fetus. This is a 36-weeker, and this is how we measure the subscapular fat thickness. So these are the cheeks of the fetus, and this is how we take the cheek-to-cheek diameter. So how do we measure the fat mass to lean mass? So this is the axial section of the upper arm taken at the level of humerus, and the outer area A is the outer circumference and B is the lean mass. So we to get the fat mass, we have to subtract area 1 minus 2, giving us the fat mass, and fat mass to lean mass ratio can be calculated, and this is normally around, it should be 0.6. So how do we use biometry for better glycemic control? If the abdominal circumference earlier is going more than 75th centile, we have to step up surveillance and tighten the glycemic control. If it is less than 75th, we can step down and maintain the glycemic control. So the role of Doppler is important because of the risk of metabolic acidemia. There is oxidative stress leading to accumulation of lactose, and this is a cause of IUD stillbirth at 38 to 39 weeks. So predictors of shoulder dystocia: if the abdominal circumference is more than 35 centimeters, this identifies 90% cases of shoulder dystocia. We can also do abdominal circumference minus BPD. If it is more than 26 millimeters, it also increases the risk of shoulder dystocia.
2 minutes.
So what are the other features that we see? Increase in liquor and placentomegaly. So how do we manage macrosomia? Expectant and elective induction of labor for term. If the fetal weight is more than 4,252 grams, an elective C-section should be performed. We have to look for the pulmonary maturity and effacement of cervix. So to summarize, pregnancy in a pre-gestational diabetic as well as gestational diabetics are associated with congenital abnormalities. Fetal growth up to 24 weeks is usually slow. There is an abrupt acceleration of growth in fetuses with GDM. There is inappropriate deposition of fat. The shoulder to trunk to head ratio will be altered due to abnormal fat deposition in the subcutaneous tissues. Fetal hypoxia and acidemia can occur. There is an increased risk of childhood obesity and metabolic syndrome, and also a transgenerational transmission of GDM. Thank you for your kind attention.
Thank you.